Welcome to the Riverbend Awareness Project.
The views and opinions expressed in this podcast episode are solely those of the individuals participating and do not necessarily reflect the views or opinions of Riverbend Media Group or the Riverbend Awareness Project, its affiliates, or its employees. It is important to note that the discussion presented is for informational purposes only and should not be construed as medical advice. Listeners are encouraged to consult with qualified healthcare professionals for any medical concerns or decisions. The Riverbend Awareness Project is a product of Riverbend Media Group.
Welcome back to the Riverbend Awareness Project, and this month we are talking about sarcoma for National Sarcoma and Bone Cancer Awareness Month, and we are excited to have Dr. Kevin Jones from the Huntsman Cancer Institute at the University of Utah with us today. Thank you so much for joining us, Dr. Jones.
Thanks for having me.
So first, we kind of wanted to ask you about yourself a little bit. Why did you decide to study medicine, and how did you end up specializing in this area?
Yeah, so I am a sarcoma specialist. By medical training, trained as an orthopedic surgeon, and then I did specialty training in the cancer part of orthopedic surgery. So orthopedics is bone and joint surgery, and the cancer part of orthopedics is really looking after sarcomas. So these are the cancers, as we often say, of flesh and bone. So if a muscle cell turns into a cancer, it is going to turn into a sarcoma. If a bone cell is going to turn into a cancer, it's going to turn into a different type of sarcoma. If blood vessels turn into cancers, they turn into sarcomas. So it's all of the tissues that are, I often say non-organ tissues in your body. So the limbs, the arms and legs, and the wall of the body. So if you have a tumor that develops in your lung, it might be lung cancer. But if it develops in your ribs or in the muscles around your lungs, then it is more likely to be a sarcoma. Okay. Does that make sense?
Yes, it does.
So I chose to specialize in that. Really, I think the piece of it that interested me the most initially was to look after bone cancers specifically. Now, bone cancers end up being actually a minority of the sarcomas that I take care of, because soft tissue cancers, soft tissue sarcomas that happen in the muscles and blood vessels and nerves and things like that of the extremities are more common than bone cancers by about 3 or 4 to 1. But bone cancers are this especially dramatic part of medicine. Bone cancers typically happen at their highest incidence in teenagers. And I think as someone who enjoys stories and enjoys meeting people and learning their stories and watching their stories unfold, there's just nothing that is more dramatic than teenagers facing these very serious challenges. And in the midst of these serious challenges that are threatening their health, threatening their lives, they're also making decisions. They're making decisions about what they want me to do with their limb. Do they want to be a walking person for the rest of their life? Do they want to run and jump and still have those kinds of activities available to them? Do they want their limb to look more normal when they're standing there? They want their limb to move more normally. All these decisions that they make that are impacted by different types of reconstruction that we can do. I found that process just really humbling and amazing to get to be a part of those decisions with patients that, again, are teenagers and young adults and are going through very, very challenging, difficult circumstances, and yet are forced with decisions in the middle of that. I thought that was amazing to be able to coach them through those decisions.
Wow. That's a really amazing answer to to how that kind of got you into where you're at now. So you brushed over what a sarcoma is a little bit, but I just wanted to know, can you tell me what a sarcoma is?
Yeah. So again, sarcomas are the cancers of flesh and bone. We often like our international group of people who look after sarcomas. We meet once a year. It's called the Connective Tissue Oncology Society. So connective tissues are sort of the tissues that connect our body and move our body. Again, these are muscles and ligaments and tendons and bones. There are also some connective tissues in organ tissues. So there are some types of sarcoma that happen within organs. I mean, there are sarcomas that happen in the lung. There are sarcomas that happen in breast tissue. But they tend to be in those organ tissues, they tend to be cancers of the stromal cells, or like the supporting network cells, that not so much the organ cells that are doing the work of the organ, the cells that are sort of providing a framework on which those organ cells build. Okay. So the connective tissues, the fleshy parts of our body. Another way to think about it is in terms of the germ layers. So if you remember way back in like high school or even junior high biology, you learned about 3 germ layers that develop as an embryo develops. You have the ectoderm, the endoderm, and the mesoderm. And so these 3 layers, with the ectoderm being on the outside, the endoderm being on the inside, and the mesoderm being in the middle, well, most sarcomas are cancers that have arisen from tissues that were derived from the mesoderm. So the ectoderm primarily becomes your skin and your nerve tissues of the central nervous system, like your brain and spinal cord. And the endoderm tends to really become your organs, in the center of your body. And so that is the source of most cancers that happen in adults, would be endoderm derived tissues, or carcinomas, cancers of epithelial tissues or glandular tissues. Well, mesoderm, or the middle tissues, this is kind of like the Lord of the Rings. It's like all the action happens in the Middle Earth. Well, if you care about sarcomas, then it's like everything happens in the mesoderm, or the mesoderm derived tissues. Now, there are some other tissues that are derived from mesoderm, but by and large, our bodies are comprised, almost 2/3 of the body is really, derived from mesodermal tissues. They are connective tissues. They are, our skeleton and our arms and muscles and legs and things like this. But those tissues don't form a lot of cancers. When they do form cancers, they become sarcomas. But sarcomas really only comprise about 1% of all cancers if you look at cancers across the human population. If you look in children and adolescents, they make up about 20% of the cancers that develop in that population particularly. But overall, cancer is a disease of older people. That is a very clearly observed phenomenon throughout all of cancers, that more cancers happen in older people. But most sarcomas happen in a little bit younger people. There are still patients of all ages that get sarcoma, but part of the thought is that we are not turning over our tissues that are in our connective tissues, or bones and muscles. They are not turning over and replacing themselves as actively as are the organ-based tissues in our body. I mean, the lining of your intestines is being turned over many, 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 many times a year. Your skeleton is turning over, at some point by the time you're an adult, at something like 1 to 3% per year. It's hardly changing at all. So it's changing a little bit. but not much. And so the thought is that while these connective tissues make up, a solid majority of our body mass, they're not a solid majority of the total body mass of our cells if you considered us across an entire lifetime, right? Because those other cells that are turning over more frequently are ultimately producing a larger number of cells across a lifetime. Okay. That gets a little bit weird science, but
no, that makes sense. I feel like, because I was like, okay, so it's like the parts of our body, the organs that the cells regenerate themselves more often. It would make sense that would be a more frequent opportunity for a cell to turn into a cancer cell, because you're getting more like turnover. That's probably not the right word, but like that's how my brain and versus.
That's exactly the right word. Yeah. You're getting more turnover. You're getting more cellular division, more proliferation or growth or of the tissues. And so that is, ultimately cancer is a process where that biology is scrambled a little bit, right? Where you're growing too quickly, you're growing with poor fidelity of copying your DNA, and things sort of get fast and loose as a cell developing. So cells that are no longer growing, no longer developing, it takes a lot to push them over the edge and to become not only a newly developing and growing cell, but one that's growing out of control. Like that is just a less frequent event.
That makes sense. What's like the difference between diagnosing a sarcoma versus a regular cancer, since it is less common and it is in a different kind of tissue? Is there a difference, or are they similar, or what is that process?
Huge difference, not only in the process of diagnosis, but in the sort of the way our medical system and our society manages these things is very different. So to compare it to the most common types of cancer, right? Breast cancer, prostate cancer, lung cancer. Those are the most common types of cancer that we see in the human population. And those are typically diagnosed because someone has a problem that they go to their doctor for, or they go for screening and they have it found by their doctor, their regular primary care doctor. And then those things are diagnosed usually by that primary care physician, or nurse practitioner or PA or whatever, whoever they see for their primary care. They are ordering some tests, sometimes getting a biopsy, and then they have a diagnosis of this type of cancer. Sarcomas, where it might present as a lump or bump that someone feels on their body, if it's a soft tissue sarcoma, it might be that they notice some pain for bone sarcomas. Those hurt, actually. And somebody usually gets some kind of imaging or can feel it on an exam. And as soon as they get to that point, one has usually reached the edge of what excellent but sort of normal physicians are comfortable with. Because these are such rare cancers, very excellent physicians see them once in a career. And so it's the kind of thing where we're usually at that point where someone has noticed a lump or a bump, or someone has noticed a lesion on a bone. Not all of those are going to be sarcomas, but when they get to that point, they usually are sending it to a specialist, and that specialist might be an orthopedic surgeon, might be a general surgeon, might be a community practice oncologist. But usually very quickly, those individuals will then send it on to us. So we get referred not all things that are sarcoma, but all things that are suspected maybe to be a sarcoma. And then that process of evaluating that and ordering additional imaging if we need it, to make a diagnosis, and arranging for or performing biopsies is kind of something that only happens really at a specialized center. I mean, we because we are looking after a large geographic population, we cover here at the Huntsman Cancer Institute, about 20% of the landmass of the lower 48 states. And that is not the most populous 20%. In fact, it's probably the least populous 20%, but it's nonetheless, it's an enormous area. And so we have patients where we are the local sarcoma center, but they're coming from a 14-hour drive away from up near the border in Montana, or up near Coeur d'Alene, Idaho, or, we have people coming from a long distance where we're the closest local, center for looking after these rare kinds of problems. The other thing that's a little bit funny about it, and just in terms of process of care, is it's a different person making that diagnosis. I mean, again, if you get diagnosed with breast cancer or prostate cancer, it's probably from your primary care physician, who is then referring you to a specialist for treatments. But in our case, like, a lot of the patients we see don't actually have sarcoma, just someone thinks they might, so they send them here. We evaluate them, and some of them we look at the imaging alone and we're like, no, this is definitely fine. You're safe. We're just going to check this again in 6 months or in a year, and we're going to confirm that it's not changing, and it's just like a birthmark on your bone. It's not really a cancer. It's just a lesion that someone noticed because they got imaging for some other reason. Or if we think it is a sarcoma, we're going to do a biopsy, we're going to make the diagnosis, and then we're going to kind of pull all the other specialists that we need to manage that, because we're not the only ones who manage it. It's not only managed with surgery, but it is almost always diagnosed by the surgical team. That's a weird thing in sarcoma. That's not true for most other types of cancer. In most of the types of cancer, you're only seeing a surgeon after your general oncologist, who's usually a chemotherapy specialist. But that general oncologist is calling in the surgeon to do your surgery, and so you'll see them for a pre-op appointment, and that's it. In our case, we're seeing patients who are suspected for having a sarcoma. We're making the diagnosis, and then we're involving the chemotherapy specialists and the radiation specialists and whoever else is needed on the team to manage the sarcoma. So it's a little bit odd in relation to other cancers because it's so rare.
Sorry, before you jump in there, Tyson, I had a follow-up question. When you were talking about how large of an area that you guys serve, how does that affect treatment or like care? Does it have an effect?
It affects it a lot. So I think it's very challenging for our patients, because again, they are trying to coordinate, and we're trying to help them, but they're trying to coordinate care at a great distance. So one thing that this is one of those sort of, if you can come up with a positive thing out of the COVID pandemic. One thing, I'm a father of what were teenagers at the time, and I sort of liked having my teenagers around. So maybe that was one positive thing. But in general, there were not a lot of positive things that came out of it. One positive thing that came out of it for us was that we do a lot of our initial evaluations, and we do a lot of our follow-up evaluations for these patients, which last 10 years after most sarcomas. We do a lot of those virtually. So we do, I don't know, I mean, more than half of my patients come from outside of Utah. And I would say a lot more than half of them, for at least some of their appointments with our team, will be, done virtually. So we will be on a video with them, looking at their imaging that they've usually gotten at their local hospital or a clinic there. And we're working with practitioners near them for some of their care. Some patients that need radiation therapy, some of them have to come all the way here to get specialized radiation that we can do here at Huntsman that we can't do in every, sort of radiation shop, around the Mountain West. But others can get excellent care. And so oftentimes the radiation oncologists will consult with our radiation oncologist, or will consult with me or one of the other surgeons, and we'll come up with a plan, and then they'll get their radiation closer to home, and then they'll only come for the surgery. Or if they're getting chemotherapy, sometimes that's a little harder, especially in some of the places in the Mountain West, and especially for our kids. So pediatric patients, adolescents with bone sarcomas are the most frequent getting chemotherapy, just because all of those patients, all the teenagers with bone cancer are going to get chemotherapy as a part of their therapy overall. And they often are having to come here for parts of their therapy, unless they happen to be in one of the very few places that are around the Mountain West where there is a center that can administer those kinds of inpatient chemotherapies. Most of those are coming here to Salt Lake for that. But some of them, for some of the doses of chemotherapy, they can get it in an office of a medical oncologist that's closer to them, at least, if not in their town. So we try to make things as convenient as we can for people, but it is nonetheless very inconvenient to be, 12 hours drive away from your doc. That's hard, especially when you're going through treatments that take a long time. I mean, we do very, very big surgeries on people that take a long time to heal, and then, or we're doing prolonged radiation courses where someone is getting radiation for 5 weeks or 6 weeks. Someone's getting chemotherapy for, 7 to 9 months for most bone sarcomas. So these are prolonged engagements with your medical team. And so it is absolutely a challenge for those patients and their families. And I mean, the amazing thing about getting to take care of this population is that we just have the best people. Like I love the people in the Mountain West. They care about their families. They will do anything to help their families get the care that they need. They are dedicated. And what's interesting here in the Mountain West, which is a little different than some other places I have been in training and things like that on the East Coast, is I feel like people still generally trust medicine, that we're trying to be honest with them and they know that. And that is great. Like I have been in places where there was a lot more distrust. That's one thing that was not a good effect of the COVID pandemic. I think that frayed a lot of trust in medicine, which has been a challenge for a lot of people on both sides of the white coat. But in general, in the Mountain West, I think our patients are just the salt of the earth. I love the patients that I get to take care of out here.
Excellent. So how and can some people detect sarcomas early? And are there issues with detecting it early?
So this is a challenge. So I mean, for common types of cancer, most of our screening tests are I guess complicated in terms of understanding the medical evidence for them, right? Like even something as common and simple as mammography for breast cancer. There are people who say that we shouldn't be screening people with mammography. There are other people who say we absolutely should screen all women over 40 or over 50 or over 35. I mean, there are all these different protocols. There's lots of disagreement. But that's for a common cancer that you're actually going to get a positive hit most of the time. if you take something that's in general, kind of a 1 in a million sort of rate, there's no way you're going to screen a population for that. It would be preposterous to screen everybody for, sarcomas of any kind, all types together. It'd be, so there are some screening things in very, very, very high risk populations. Like if you're in a family that is one of these cancer families that has Leaf-Romani syndrome, which is like the big cancer gene that we all learned about a long time ago, called TP53. If you're in a family that has a mutation in TP53 that runs in your family, you're going to get an MRI probably every year looking for, many times, sarcomas are the cancers that happen to those patients. But anybody else is never going to be on a screening type of a program. What most people notice for soft tissue tumors is a lump somewhere. Most of them are not painful. Many lumps are painful, but most lumps that are actually dangerous in terms of being a sarcoma are not painful. There are a few subtypes that have a little bit of an ache associated with them, but most are not very painful. Complete opposite with bone sarcomas. Bone sarcomas, again, mostly in teenagers and young adults, they hurt, and they hurt like a toothache. And so I would say the most common scenario that they're confused for is someone thinks that their kid has growing pains. It's a vague ache, usually around the knee. And so that's what will bring people in with that.